This is Dr. Michelle Cotty. Today we are going to discuss a brief introduction to mental health issues of children and adolescents. The objectives for today's lecture include to identify disorders that can appear during childhood and adolescence, list the characteristics of good mental health, assess for risk factors of depressive disorders, and identify expected findings of mental health issues of children and adolescents. Treatment and interventions can be delayed in childhood and adolescent mental health because they're not always easily identified or diagnosed. Just like adults, children or adolescents might meet the criteria for more than one mental health disorder and have comorbid health conditions. Behaviors in children are often noticeable when it interferes at home or at school and in interactions with peers. So just like adults, children can experience depressive disorders, anxiety disorders, PTSD. They may struggle with substance abuse. They may have disruptive, impulse control, or conduct disorders. These things could include oppositional defiant disorder, disruptive mood dysregulation disorder. They may experience neurodevelopment disorders, and this would include ADHD, autism spectrum, or intellectual development disorders. Bipolar and schizophrenia can occur when children are younger, but often it doesn't until they're in their late 20s. We also might see suicidal behavior or non-suicidal self-injury like cutting. And then impulse control disorders such as intermittent explosive disorder. There are many factors that can impede an accurate diagnosis for mental health issues in children and adolescents. Children may not have the language skills or cognitive and emotional development to describe what is happening. Depending on the developmental stage, there's a wide variety of what's considered normal. It's hard to tell sometimes if a child's behavior, which might just be indicative of poor parenting, is a mental health problem or if it's actually an emotional struggle. Good mental health might be easier to identify. So if the individual can appropriately interpret reality and have an accurate perception of what's going on around them, that's a sign of good mental health. Positive self-esteem, a healthy way to cope with stress or anxiety in a way that's age appropriate would be healthy. Mastery of developmental tasks, the ability to express oneself spontaneously and creatively, and the ability to develop or maintain satisfying relationships. So these are all characteristics of good mental health. One of the most important things that we do as a nurse is assessment. So we need to really pay attention to assessing the patient. So when we're doing an assessment of children and adolescents, we want to look at etiology and general risk factors. Genetic links or chromosomal abnormalities would be included in that assessment. Biochemical alterations. So alterations in neurotransmitters, including norepinephrine, serotonin, dopamine, those can all contribute to mental health disorders. Social and environmental, marital discord, low socioeconomic status. If we're thinking of ACE scores, think about the social and environmental factors that can occur. Cultural and ethnic differences. So if an individual has difficulty with assimilation, lack of cultural role models, a lack of support from a dominant culture, these things can contribute to mental health issues. Resiliency, we've talked about resiliency scores. So the ability to adapt to changes in the environment. Are they capable of forming nurturing relationships, having healthy coping strategies, using problem-solving skills? Witnessing or experiencing traumatic events during the formative years put children and adolescents at a higher risk for developing mental health issues. Risk factors for depressive disorder include family history of depression, physical or sexual abuse or neglect, homelessness, conflicts with family, peers, or rejection by family or peers, or disputes just amongst parents. Bullying, which can be cyberbullying also. High-risk behaviors, learning disabilities, and chronic illness. Things that we might expect to find are feelings of sadness, temper tantrums, crying, irritability, aggression, complaints of just not feeling good, kind of isolating. So playing or working by themselves at school, changes in appetite or sleep, poor school performance, feelings of hopelessness, giving away things they love, and suicide attempts. Anxiety disorders and trauma stressor-related disorders. So anxiety or level of stress can interfere with normal growth and development. It can be so serious that the child or adolescent can't function normally at home, in school, in friendships. So separation anxiety is characterized by excessive anxiety if the child's separated from home or parents. And this would be if it were developmentally inappropriate. So it's normal at certain ages to feel scared or sad when a parent leaves, but we're talking about when it's developmentally inappropriate. And this anxiety can develop into a school phobia or a phobia of being left alone. Depression can also be part of this. Anxiety can develop after a specific stressor, so a death of a relative, a pet, an illness, if they've moved, been assaulted, and it can progress to panic disorder or another type of phobia. Now, just like adults, children and adolescents can experience PTSD. So PTSD occurs when someone witnesses or experiences or learns about a really traumatic event. They can exhibit anxiety, depression, phobias, a conversion reaction. If the anxiety from PTSD is displayed externally, it is often manifested as irritability and aggression with family and friends. You might see complaints that are somatic in nature, so like an upset stomach, a headache, poor academic performance, insomnia. Kids can show a decrease in wanting to play. And so that would be a sign that maybe we should screen them for PTSD. So when we're thinking about these disorders, we want to also think about medications. And a medication for PTSD would be targeted to the problem areas associated with the disorder. So either depression or ADHD. Individuals who experience PTSD may have a really difficult time with concentration. So what is the nursing intervention we do for an individual who has an anxiety disorder? We want to provide emotional support. So therapeutic communication is really important. These individuals may have some pretty strong defense mechanisms or regression, and we want to make sure that we are non-judgmental. Offer reassurance when an individual is having a panic attack and try to provide a safe space for them. We want to help them by working with them to increase their self-esteem and feelings of achievement. So for trauma and stressor-related disorders, we want to help the individual work through the traumatic event or losses, and the goal is to reach an acceptance or closure of the event. We want to encourage group therapy. These individuals, of course, may also need individual therapy. But your book says group therapy is what we want to encourage. Disruptive impulse control and conduct disorders. So in these disorders, the expected findings include behavioral issues that occur in school, home, or social settings. These individuals may also have ADHD, depression, anxiety, substance use disorders. In children and adolescents with these disorders, their behavior is often worse in situations that require sustained attention, like the classroom, or in unstructured group settings, like the playground. Intermittent explosive disorder is an example of a disruptive impulse control or conduct disorder. And in this disorder, these individuals have recurrent episodic, violent, and aggressive behavior with the possibility of hurting people, property, or animals. They're typically diagnosed between the ages of 13 to 21, but can be diagnosed as early as 6 years old. More males are diagnosed with this disorder, and these individuals are often verbally or physically aggressive. These are overreactions to normal events, and then they feel ashamed of themselves and regretful. This obviously can lead these individuals to struggling having healthy relationships or holding a job, and it can even lead to development of chronic disease like hypertension, diabetes, and other health disorders. So that's intermittent explosive disorder. Oppositional defiant disorder. This disorder is characterized by a recurrent pattern of the following antisocial behaviors: negativity, disobedience, hostility, defiant behaviors, especially aimed at authority figures, stubbornness, argumentativeness, limit testing, unwillingness to compromise, refusal to accept responsibility for misbehavior, and the misbehavior is usually demonstrated at home and directed toward the person that they know the best. They do not see themselves as defiant. Instead, they think that the demands are unreasonable and therefore this behavior is acceptable. So really poor insight. They may have low self-esteem, labile mood, and a very low frustration threshold. This can eventually develop into conduct disorder. Disruptive mood dysregulation disorder can be diagnosed if the manifestations are not due to another mental health disorder like bipolar, for example. So individuals with this disorder have recurrent outbursts that are severe and do not correlate to the situation. They may happen 3 or more times a week in 2 or more settings like school and home. And they're not appropriate for the client's developmental level. The mood between the outbursts is angry and irritable, and this onset of this disorder usually occurs between 6 and 18 years old. Conduct disorder. Clients who have conduct disorder have a persistent pattern of behavior that violates the rights of others or rules and norms of a society. So they may be aggressive to people and animals, destroy property, be deceitful, steal things, and violate laws and rules. It usually develops before the age of 10, is more prevalent in males, and after the age of 10, the ratio of males to females is more equal in the adolescent stage. So in childhood, it's more often males before the age of 10. And adolescent onset is after the age of 10, and the male to female ratio is more equal. So, contributing factors. If an individual experiences parental rejection and neglect, they are at higher risk. Maybe they had a difficult temperament as an infant. There's inconsistent parenting practices with harsh discipline, abuse, physical or sexual, lack of supervision, early institutionalization. Maybe they have a large family size, frequent changing of caregivers. If their friends have a history of delinquency, then they are at higher risk, or a parent with a history of a psychological illness. A chaotic home life and a lack of a strong male role model may also be a reason this occurs. So what does this look like? Well, these individuals lack remorse or care for feelings of others. They may bully, threaten, or intimidate others and believe that their aggression is justifiable. They might have low self-esteem, feel irritable, have temper outbursts, reckless behaviors. They may have suicidal ideation and also learning disorders or impairments in cognitive functioning. They often demonstrate physical cruelty to others and or animals and may have used a weapon that could cause serious injuries. They destroy property of others, have run away from home, lie, shoplift, truancy from school. These are all manifestations of conduct disorder. Again, it can have childhood or adolescent onset. Interventions for disruptive impulse control, conduct disorders, and ADHD, which we'll get to momentarily, include the following. Use a calm, firm, respectful voice when you're speaking to the child. Role model acceptable behavior. Obtain the individual's attention before giving the directions, and then make sure the directions are short and clear. Set clear limits on acceptable behaviors and be consistent. Plan physical activities so that we can get that energy out. Assist the parents. We want to use a token economy reward system. So that's when they get good behavior, they get tokens, which then they can exchange for things. Sometimes this might be one-on-one time reading or going to the park. Focus on everybody's strengths, not just the problems. We want the parents to be supported and to remain hopeful. Provide a safe environment for everyone. And provide the child with specific positive feedback when they meet expectations. We want to eliminate power struggles. So identify the areas where these occur. And we want the child or adolescent to have effective coping mechanisms. Encourage them to participate in group, individual, and family therapy. And we will administer them medications and monitor for adverse effects. Attention deficit hyperactive disorder is categorized in different categories. So inattention is evidenced by difficulty in paying attention, listening, and focusing. Hyperactivity is evidenced by fidgeting, running and climbing inappropriately, excessive talking. Impulsivity is interrupting others and acting out without considering consequences. These behaviors can put the child at risk for injury, and they must be present prior to age 12 and in more than one setting to be diagnosed as ADHD. Individuals who have ADHD often get negative attention from adults and peers. So when we diagnose this, it would be called ADHD predominantly inattentive type, or predominantly hyperactive impulsive type, or combined type. Autism spectrum disorder is thought to be genetic, and it can impact a wide variety of behaviors, including communication and interaction with others. These individuals may struggle to maintain eye contact and like to observe routines really strictly. They also might have repetitive actions. It's thought to be more common in boys than girls. And they may have a hard time with sensory integration, so the feeling of clothes might bother them. They may experience sleep disorders, digestive disorders, feeding disorders, even epilepsy or other allergies. But the functioning of these individuals really ranges from the inability to perform self-care and communicate to really high ability. So autism spectrum disorders may be treated with medications at times with SSRIs or antipsychotics, and ADHD is treated with stimulants like Adderall or medications such as Strattera. Interventions for autism spectrum disorders are listed below. They include therapy such as physical, occupational, or speech therapy, a structured environment, consistent and individualized care, short, concise and developmentally appropriate communication. We want to identify the desired behaviors and reward those behaviors. We want to role model social skills and conflict resolution, limit self-stimulation and ritualistic behaviors by providing alternative play activities. We want to identify triggers and discuss any routine changes well before they happen. Remember, safety first. Individuals with intellectual development disorders usually have the onset of deficit and impairment during infancy and early childhood. So these deficits include reasoning, abstract thinking, academic learning from prior experiences, and they may have a hard time with activities of daily living like brushing their teeth, brushing their hair, and they may need a lot of support at school. These deficits can range from mild to severe. Specific learning disorders are when an individual has difficulty in an area, such as reading or math, and their performance in that area is lower than expected for their age and level of intelligence. So they would benefit from an individualized education program, or IEP. Patient-centered care. So we want to obtain a complete nursing history, and that would include the following items: the mother's pregnancy and birth history, sleeping, eating, and elimination patterns, attachment behaviors, weight gain, weight loss, achievement of developmental milestones. How old were they when they walked, said their first word, crawled? Are they on any current medications? Do they have any allergies? How are their relationships with peers, with family members? How do they do in school? Do they have a history of emotional, physical, or sexual abuse? How does the parent perceive the child's behavior? And we want to know about the family's history. That includes members of the current household, even if they're not blood related. Is there any substance use? That includes tobacco, e-cigarettes. Are they safe at home and school? Are they at actual or potential risk for self-injury? Do they have depression and suicidal ideation? Does that include a plan? And do they have the means to carry out that plan? Are there weapons in the home? Also, perform a complete physical assessment. That includes a mental status exam and a developmental assessment. We always want to use primary prevention, and we can do that through education, peer group discussions, mentoring. We want to prevent risky behavior and promote healthy behavior and effective coping. We want to work with these individuals to adopt a realistic view of their bodies and improve their self-esteem, so a healthy body image. We want to reinforce positive coping skills and teach them. We want to make sure that if there are guns or weapons in the house, that they are secure. And we want the children and adolescents to wear seatbelts, helmets when they're riding bikes, use contraceptives and condoms to prevent STIs. We want to give them options for professional help and therapists as needed. For children and adolescents who have already engaged in high-risk behaviors, we want to talk to them about what are the risk factors for substance abuse. We may want to link them with support groups. There are support groups for eating disorders, substance abuse disorders, families that have gone through divorce. We want to be able to give them resources where they can talk to people if they feel like they are not safe or they're being bullied. So for some people, this may be police officers. For others, it might be school nurses, counselors, teachers. We want to make referrals to social services if needed, and make sure that we're doing a depression and suicide assessment. Make an immediate referral for professional help when indicated.